So far, we've learned about all the various diseases that can cause dysphagia or difficulty swallowing in a very similar fashion to how you would learn about it in school. In other words, I tell you the disease and I tell you everything about it. But that's not really how you're going to be tested on the PANCE. They don't just say, hey, tell me everything you know about eosinophilic esophagitis. Instead, it's going to be, hey, you have a patient who's coming in with a very specific complaint. What are you going to do next? My name is Maruf, and in this video, we'll take everything that we've learned about the previous disorders that can cause dysphagia and come up with a nice, clean algorithm so you always know what to do next. Let's dive right into it. Now, the first thing I want you to do when you have a patient coming in with dysphagia is determine, are they stable or are they unstable? Because that will significantly change your next step. For example, if your patient has dysphagia, but they also appear to be drooling or have some sort of respiratory distress, then you should presume that there is some sort of complete esophageal obstruction, and this is a very unstable patient. You have to keep in mind that you create about a liter of saliva per day. So when you have this complete esophageal impaction, you have nowhere for all that saliva to go but into your airways and to cause respiratory compromise. In this situation, the next step is going to be urgent endoscopy to help you visualize that problem and treat that underlying cause. Now, of course, make sure you stabilize their ABCs first, but in reality, the boards would probably expect urgent endoscopy as your next answer. You have to keep in mind that a majority of these patients who present this way are often having esophageal food impaction from eosinophilic esophagitis. That tends to be the most common reason. So to summarize, if you have a patient coming in with dysphagia and drooling or some sort of respiratory distress, then automatically your next step should be endoscopy. Nice, easy point without too much thinking about it. Now, if your patient is stable, then the next step should be instead to localize where that problem is. If you think about it, dysphagia technically can fall into two types of dysphagia, an oropharyngeal dysphagia or an esophageal dysphagia. So if your patient is coming in with difficulty with initiating swallowing, then they're most likely suffering from an oropharyngeal dysphagia. Usually these patients will also have underlying neurologic diseases, which should further increase your suspicion for oropharyngeal dysphagia, since diseases like dementia, Parkinson disorder, prior strokes, they all cause weakening of that neurologic input that you need in order to initiate that swallowing process. Now, historical features of aspiration or frequent choking should also increase your suspicion, since these symptoms are very common in patients with oropharyngeal dysphagia. So pretty much if you see that pattern where you have an initiation issue, especially if they have an underlying neurological history or even history of frequent choking, then you should presume oropharyngeal dysphagia. In that case, your next step will be to perform a barium swallow to help you confirm that diagnosis. Again, another easy point here without too much complexity. If instead of an initiation issue, your patient is instead saying, hey, I feel like something is getting stuck right in my throat, then the esophageal dysphagia is the most likely diagnosis, and you're most likely dealing with one of these 5 diseases. This is where the PANCE really focuses all of its attention. So the next step will be to determine what is the pattern of dysphagia that this patient is presenting with. What you'll see is that each disease has a very classic presentation, and the PANCE will monetize on this. They'll always use these patterns to suggest the most likely disease. You just have to be on the lookout for it. For example, if the patient that you're presented with has dysphagia, but they're also complaining of regurgitation of solid or undigested foods, then you're most likely dealing with Zenker diverticulum. Now, in Zenker diverticulum, you have a piece of the esophagus that herniates through Killian's triangle, which is an area of natural weakness along that posterior esophageal wall. That's going to create this new purse-like sac that will allow for food to get stuck in there for days, often leading to classic halitosis or stinky breath. Now, if you have a patient with dysphagia, that classic regurgitation or halitosis, then Zenker is your leading diagnosis, and the next step is to perform a barium swallow to confirm that diagnosis. On barium swallow, you should see the anatomical outline of that Zenker pouch just posterior to the esophagus. Now note that most of these patients still undergo endoscopy and biopsy down the line to rule out malignancy, since that is always going to be the biggest concern that you have when a patient comes in with dysphagia. But this is not your first test. Eventually, these patients are going to undergo cricopharyngeal myotomy as their definitive management for their Zenker diverticulum. That's where you're going to cut that septum between the Zenker and the esophagus to make it into one combined lumen. Now, what if you're presented with a patient who has dysphagia but also complains of heartburn? Then you are most likely dealing with esophageal inflammation from GERD, since GERD is the most common cause of dysphagia overall. In these situations, the next step will still be to do an endoscopy with biopsy, even though there's nothing specific that you're looking for on endoscopy for GERD. Instead, you have to remember that dysphagia is a very red flag symptom, and you are performing dysphagia to rule out any possibility of esophageal cancer instead as the cause of the patient's dysphagia. So, an important concept to understand here is that while most patients with GERD will just get empiric PPI treatment as their first step, once they develop dysphagia, malignancy is the number one concern, and endoscopy with biopsy has to be next. Now, what if you're presented with a patient with dysphagia, but they also have signs of atopy? Then you should immediately think that this patient has eosinophilic esophagitis. Often these question stems will have patients with a history of nasal polyps, eczema, or asthma as a way to cue you into the disease. Now, in these situations, the next step again is going to be endoscopy with biopsy, which will help to confirm your diagnosis. Remember that we're looking for that classic eosinophilic infiltration within that biopsy, which is absolutely required for you to confirm that diagnosis. Now, sometimes the boards will provide you with some stereotypical findings of EOE on endoscopy. For example, they might say the patient has white exudates, concentric rings, linear furrows. But remember that these findings are suggestive of EOE. They are not confirmatory for EOE. The only way you can confirm EOE is by looking on biopsy, where you'll see that proof of eosinophilic infiltration to confirm your diagnosis. Once you confirm the disease by biopsy, then you can start the patient on either a PPI, an inhaled steroid like budesonide, or on diet elimination therapy. If you're presented with a patient who has dysphagia, but they specifically state that when I first started feeling my symptoms, I had both solid and liquid dysphagia at the same time, then this is achalasia until proven otherwise. Remember that achalasia is caused by a dysfunction of the myenteric plexus, which is going to lead to a tightening of your lower esophageal sphincter with absence of peristalsis of your esophageal body. In these situations, the next step will be a barium swallow, which will show suspicions for that motility disorder like achalasia. If you see that iconic bird beak pattern where the dilated esophageal body is meant to resemble the head of the bird and the tightened lower esophageal sphincter is meant to resemble the beak of the bird, then the next step is to confirm the diagnosis by performing an esophageal manometry. On manometry, you should see that hallmark high pressure at the lower esophageal sphincter and the lack of peristalsis at the esophageal body. Once you've confirmed the diagnosis of achalasia on esophageal manometry, the next step is to offer them pneumatic dilation as the first line of treatment, where you go in endoscopically and dilate the esophagus with a balloon. Now, of course, if your patient can't go through pneumatic if your patient can't undergo pneumatic dilation, like they're old or there are concerns for esophageal perforation, then you can offer Botox injections instead to temporarily relax that esophageal sphincter. Now, if the patient says that they have dysphagia, but it's progressively worsening from solid to eventually liquid, then this is esophageal cancer until proven otherwise. Often, they might include risk factors in the clinical vignette like an older age, smoking history, drinking history, Barrett's esophagus, all the things that we know will increase your risk of developing esophageal cancer. In this situation, the next step is to perform an endoscopy with biopsy to confirm that diagnosis. Remember that if esophageal carcinoma is confirmed on endoscopy, then your treatment options are going to vary based upon the stage and histology of the cancer, ranging anywhere from chemo and radiation all the way up to surgery. By combining everything that we just talked about, we can come up with this nice, clean algorithm on how to approach a patient with dysphagia. So I just want you to take a couple seconds to appreciate this stepwise approach, and then we're going to apply it to a question. So let's apply that algorithm that we talked about to this following question. Now, this patient clearly doesn't have any alarm symptoms of concern, nor does he have a presentation for oropharyngeal dysphagia, since we don't see that concern for initiation of swallowing, nor do we see any history of neurologic diseases to support that. So we can presume that this patient is likely dealing with an esophageal dysphagia, and the next thing to determine is what is their pattern of dysphagia. This patient specifically has a classic pattern of solids progressing to liquids, as well as risk factors for cancer, therefore making esophageal cancer the most likely diagnosis. Now we can take this one step further, and by following the decision tree, we know that the next step for this patient must be endoscopy with biopsy to confirm your diagnosis. So as you can see, by using this algorithm, you can take a complex appearing clinical vignette and always know what your next step will be. I hope you enjoyed this video. I'm going to work on a next chest pain module as well as an approach to chest pain, so I hope to see you there.